Topic of the lecture today is pulmonary neoplasm. We're going to discuss about all the neoplasia occurring inside the pulmonary system. That neoplasia might be benign, that neoplasia might be malignant in nature. We're going to discuss about all the tumors, all the cancers which are benign in nature and stay inside the lungs. We're going to talk about pulmonary tumors. We're going to talk about extrapulmonary tumors. We're going to talk about which tumors go and metastasize. And we're going to talk about which tumors have better prognosis, which tumors have the worst prognosis. So let's go on to it with the most benign tumor in our body we have regarding the lungs. Pulmonary hamartoma. It's the most benign tumor present inside the lungs. It's chondratous in nature. Sometimes it's chondratous in nature. So the point regarding pulmonary hamartoma that you have to remember is that it has not distinctive but mature hyaline cartilage which is surrounded by fibrous tissue, and sometimes, just sometimes, it has soft tissues plus ossifications and calcifications present. It occurs in 40s to 60s, patients who are between 40s to 60s, and most commonly smokers are going to get it. So it's common in smokers. First point, it's common in smokers. Second, it occurs in 40s to 60s. Third point, it's chondratous in nature. And fourth point, you have to remember that if you did smoking for quite a while and then even you quit, quitting the smoking will definitely reduce the chances of it happening, but it will never eliminate it. So let's get on to the 4 points that you have to remember. First of all, malformation and true tumors. Next one we have typically occurs in adults, 40s to 60s. Next one we have accounts for 10% coin lesions. That's actually the radiological finding of pulmonary hamartoma. It accounts for 10% in the cases in radiological finding. You're going to find coin lesions in 10% of the cases. Next one, popcorn pattern of calcification. We just talked about that it has ossifications and calcifications, but they're nodule in form. When you look at it, it will seem like there's some popcorn type calcification happening around. So actually they're nodules. It's calcification and ossification. So you learned all of this. Next on, we have pathology. On a pathological slide, if you can differentiate, if you can identify, there's this cartilage. You can easily identify the cartilage present here. We just talked about it has a mature cartilage which is surrounded by fibrous tissue. And you can see even the glands, these white glands on the side of it. So all of those things we just talked about, that it has hyaline cartilage, it is surrounded by fibrous tissue, it has glands in it, and it has ossification and calcification. All of that can be depicted here right there. Next on, we have pulmonary hamartoma morphology. This is what it looks like. If you go for morphology, this is what it will look like. You can easily see the calcifications. You can easily see how destroyed it got. But the point to be noted is it never metastasizes. It stays the same. It stays benign. It never goes away. It never enters the bloodstream. It never enters any of the other organs. So the point to remember in pulmonary hamartoma is that it occurs mostly in smokers. It has hyaline cartilage in it, which is surrounded by fibrous tissue. Then ossifications and calcifications are there. It's benign in nature. It never metastasizes. And quitting the smoke will definitely reduce the chances of it happening, but never eliminate them. So these are the takeaway points for pulmonary hamartoma. So this was a benign tumor. This was the most benign tumor. It usually has a size of less than 3 centimeter, or maximum it goes up to 5 centimeter in some cases. It never even exceeds that. Next on, we're going to talk about carcinomas of the lung. Now we get into the proper calcification. Now we get on to the proper carcinomas. So let me tell you that this is a healthy lung. A lung which has a vasculature, both of the lungs are working fine, heart is pumping there, sending all the blood from right ventricle to the lungs and getting it back into the left atrium. It's a normal and healthy lung. What happens if the patient develops cancer? The point is point where the patient is getting the cancer, that point or that area does not communicate with the blood anymore. That area is not even there yet and it's metastasizing. And at the end, it leads to this stage, late stage cancer, the stage at which you can easily see that most of the area is compromised, lungs are not functioning. What will happen? Severe symptoms will start appearing. Pulmonary systems have already appeared. Further on, it will metastasize, it will get into the bloodstream, and not only heart, but other organs might get affected afterwards. So these three stages, these three depictions that are shown here depicts that what is a normal lung, what is a late stage cancer, and you can easily see how can a person respirate through that late stage cancer lung. They cannot. So they cannot survive. Next on, we're going to talk about the stages of the lung cancer. But before we get into the stages of the lung cancer, what happens? Actually, how lung cancer develops? That must be a question. What will be the histological finding? What will be the histological pattern of it forming lung cancer? First of all, what happens is that basal membrane proliferates. Basal membrane starts proliferating. Now, remember, this is a process which may take years. It's not a process that happens in one night or 2 nights or 1 month of smoking or 2 months of smoking. No, it's going to take some time. It's going to take years. So when I tell you these consequences, it means they have happened along a long time. They didn't happen overnight. So first of all, basal cell proliferation starts. It may take months, it may take years. Once the basal cell proliferation reaches its maximum, what happens? Metaplasia happens. Of which cells? Goblet cells. Now, not actually metaplasia, actually it's hyperplasia. Hyperplasia of the goblet cells will happen. Now, goblet cells will be more and more. Now comes the metaplasia. Metaplasia is changing of membrane. Metaplasia of stratified squamous epithelium will happen. It will be changed, literally changed from its own nature, from its original self, from its original composition. The composition which a normal lung holds, it will not hold that anymore. So what happens is that metaplasia of the basal membrane will happen. Once the metaplasia of the basal membrane happens, one day or another you're going to develop carcinoma in situ. Once you develop carcinoma in situ, it's going to increase in size. One way or another, it's going to get into your bloodstream. Next on, it's going to infiltrate that basement membrane that we talked about. That basement membrane that was proliferating. Now it's going to infiltrate that, and whenever a tumor infiltrates the body, where does it first go? What's the first destination for the tumor after crossing that organ? Which is it affecting? It's going to go into the regional lymph nodes, and it's going to go inside the whole body afterwards. Once it reaches the lymph nodes, it's going to disseminate inside the bloodstream. It's going to disseminate in the bloodstream. Once it disseminates in the bloodstream, it goes viral. It goes inside all of your body. It can get inside any of your organs which are supplied by blood. And virtually every organ, every tissue, and every cell is supplied by the blood. So it can get anywhere. And that's how the lung cancer metastasizes. That's how the lung cancer progresses. So now we can discuss the stages of lung cancer. We know now the pathology of lung cancer, that how does it propagates, how does it reach that stage that we just talked about, that, okay, we talked about that the patient is suffering from third stage cancer. What does third stage cancer mean? I'm going to tell you that. But you have to know, how did that reach there? How did that small cancer cell, which was inside of your lung, got up to your regional lymph nodes, got up to your bloodstream, got up to your other organs? So we have actually 4 stages. We're going to discuss all of them in details. So stage 1, you can see there's this one little bunch of cells, cancer cells. Stage 2, it's moving up. Stage 3, it's moving to the sternum and into the regional lymph nodes. And stage 4, it disseminated. So we're going to talk about all of these in details now. But before that, we have to know which subtype are we talking about. We have different types of lung cancer. Every lung cancer propagates at its own speed. Every lung cancer has its own specificities. So first of all, let me tell you, you're going to listen to this term a lot. Small cell carcinomas and non-small cell carcinomas. Now, these are the basic types of lung cancers. Further on, all of them are subtypes of them. So you have to know that small cell carcinoma and non-small cell carcinoma are the basic types of carcinoma of the lung. And which is the most dangerous one? Small cell carcinoma. If you're diagnosed with small cell carcinoma, even the doctors won't ask you to go for chemotherapy or any kind of treatment if you're up to that stage. So we're going to talk about the subtypes of carcinoma of the lungs now. First of all, we have adenocarcinoma. Now, adenocarcinoma, first of all, let me tell you that these names suggest something. These names are not just random. Adenocarcinoma means this adeno means this type of cells are present inside of that carcinoma. This type of cells are seen on the histological pattern. So adenocarcinoma is actually the most common tumor in the patients. The main affected part, the people who get affected by adenocarcinoma are those people which do not smoke, and mainly women. So you always talk about that a smoker is going to get this, a smoker is going to get that. So this adenocarcinoma is the only tumor which occurs in those people who do not smoke, and those women who never even thought of smoking. So adenocarcinoma is very different from all kind of cancers. It happens in the peripheral areas of the lung, and it propagates at a very high speed. It propagates very quickly. Next on, we have squamous cell carcinoma. Now, squamous cell carcinoma is most common in smokers. Smokers and non-smokers side by side here. So squamous cell carcinoma happens in smokers, but it propagates very slowly. It propagates so slowly that it takes decades for the patient to get it, for the patient to reach up to that state that there's no turning back. Next on, we have small cell carcinoma. I just told you, small cell carcinomas are also called oat cells carcinoma. Why are they called oat cell carcinoma? Because they look like oats. Just look at it. They look like oats. Whenever you'll see the morphology of it or histopathology of it, you're going to see these look like oat cells. So that's why it's called oat cell carcinoma. So next on, we have further subtypes. We have large cell carcinoma. Why it's called large cell carcinoma? Because it contains large cells which have no physiological value of any kind and any kind of cell inside the body. They're pathologically large. That's why it's called large cell carcinoma. It also occurs in the peripheral areas, of the lung. Next on, we have carcinoid tumors. These are tumors which cannot be placed under any other subtype. These are very random cells bunched together. That's why it's called, even for a cancer, it's so random that it's called carcinoid tumor. Next on, we have adeno-squamous carcinoma. Now, adeno-squamous carcinoma has a secretory value. Remember that. This is very unique in all of these tumors. It has secretory value. It also occurs in the peripheral areas, and it's going to happen to those people who smoke a lot. Obviously, smoking is a big risk factor. But what other risk factors that we talk about when we talk about all these carcinomas of the lungs? We talked about that adenocarcinoma is the only carcinoma that occurs in those people who do not smoke. But other than that, all of these carcinomas are occurring in those people who are smoking. So one thing I have to get out of it is what are the risk factors of getting the cancer? Smoking, yes, top of the notch. Smoking is the risk factor. But what else? People who are exposed to radiations, people who are exposed to substances like asbestos, like mercury, this kind of substances, people who work in mines, people who have a genetic predisposition of getting it, people who have a family history of cancer, people who are immunodeficient, people who have been exposed to ultraviolet lights. All of these are risk factors for getting the cancer. It's not only smoking. So these are risk factors that are going to affect whether you're going to get the cancer or not. Even most smokers don't get cancer their whole life. So it's not like smokers are going to get it. These other risk factors are very important. Next on, now let's stage the cancer. Why staging is so important? Staging is very important because with the help of staging, we can actually tell the patient that how long does he have. But not only this, it's very important for the choice of treatment. If a patient is suffering from stage 1, we have a different treatment plan for that. If a patient is suffering from stage 2, we have a different treatment plan for that. And if a patient is suffering from stage 4 and there's no turning back, we go for supportive treatments. And those treatments which won't stop the propagation, but at least alleviates the person, at least alleviates the patient. So for these two purposes, we need staging. And you cannot just go on and tell every person that I have cancer in lungs, I have cancer in liver, I have cancer in these lymph nodes. It's very easy to tell a person with the help of staging. And the type of staging that helps us doing it in lung cancer is TNM staging. We're going to talk about TNM staging in a while. First of all, what does T stands for? T is actually the size of the cancer. T is the size of the cancer. You have to remember that. So the patient is suffering from T1 stage if the tumor is more than 3 centimeter and is surrounded by lung or pleura. That's when we call that this is stage T1. Next on, if the tumor is more than 3 centimeter but less than 7 centimeter and involves main bronchus or visual pleura, it's called T2 stage. Next on, if further T2 is divided into T2A and T2B. So if more than 3 but less than 5 centimeter, it's T2A. And if more than 5 but less than 7, it's T2B. So we subdivided it because from 3 to 7, it's a huge difference. 4 centimeters is a huge size. We cannot say that a patient is suffering from cancer and he has a size of 4 centimeter and a patient is suffering from cancer and he has a size of 7 centimeter. We cannot say they're the same stage. That 7 centimeter guy is way ahead. So we subdivided them whenever it was feasible for us to make the understanding, to make the treatment plan. So we have T2A, we have T2B. If it's more than 3 but less than 5, it's T2A. If it's more than 5 but less than 7, it's T2B. Next one we have T3. So T3 must be more than 7 centimeter, obviously. So tumor more than 7 centimeter or tumor involving the chest wall, diaphragm, pleura, and nodules. So all of these will be involved in T3 stage. What happens in T4? T4 is tumor involving the mediastinum, heart, crania, or separate nodules. T4 is such an advanced stage that it has involved the mediastinum, heart, crania, or separate nodules. So whenever you will be asking some guy that what stage he's on and he goes for T4, you know that involvement of these structures is already in there. So all of these, we just discussed that it starts from this, it starts from this, it involves this, it involves that. We just have to know one thing, one very basic thing that you have to remember for your exam, that most of these carcinomas start at the level of bronchi or bronchus. Like 90% of them. Some also develop in alveoli, trachea, bronchioles, but most of them start at the level of bronchus. So you can see involves main bronchus. All of them are going to involve bronchus and other structures. So you have to know which is the best place or which is the part where the cancer propagates, where the cancer starts, where the basal proliferation starts. Now let's talk about N. We said it's T and M staging, right? So T was size. We talked about the size. We talked about T1, if it's T2, whether it's T3, whether it's T4. We talked about different sizes present inside of them, then what sizes will be them. So now let's get on to staging of N. So what is N0? N0 is no demonstrable metastasis to regional lymph nodes. You check the lymph nodes, there is no metastasis. So it's N0. Or you can also, some people also called it NO. Next on, we have ipsilateral hilar or peribronchial nodal involvement. Ipsilateral meaning on the same side. That if the patient is suffering from a cancer of the left lung, the hilar lymph nodes and peribronchial node of the left side will be involved. That's called N1. The contralateral side is fine, but ipsilateral side is affected. Next on, we have N2. Metastasis to ipsilateral mediastinal or subcranial lymph nodes. Now, it's still ipsilateral, but the propagation has increased in both ways. It has reached to subcranial lymph node, it has reached to ipsilateral mediastinal lymph nodes. Next on, we have N3. N3 is metastasis to contralateral mediastinal or hilar lymph nodes. Now, the stage is N3 and it has actually crossed the paths. It was on the left side. Before that, all of it was happening on the left side. All of the ipsilateral hilar lymph nodes and subcranial lymph nodes were being involved. But now it has shifted. And what do you concur when we say shifted? It's going to affect sternum in between. And then it's going to cross, and then it's going to reach to this level that it affects the contralateral side of the lymph nodes. So this is N staging. We talked about T. That's a size. We talked about N. N stands for nodal involvement. Next one, we have M. What does M stands for? Let's find out. First of all, we have M0 or MO. MO is no distant metastasis. M stands for metastasis. Next one, we have M1A. M1A means separate tumor nodule in contralateral lobe, separate pleural nodules or malignant pleural effusion. It means it has metastasized, maybe to the contralateral lobe, but it's still inside the lung. So it's M1A. Next one, we have M1B. That means it has distant metastasized. It has reached the bloodstream, it has distant metastasis now, even it gets to the level of brain, even if it gets to the level of liver, it can go anywhere, and the first organ it's going to affect is heart. So, we learned about T&M staging. Now I hope you can understand what T&M staging stands for. Let me give you an example so that you might get it better. A person comes to you and says, I have a tumor size of 2 centimeter. That means patient is suffering from T1 stage. There are no nodes involved, meaning N0, and there's no metastasis. That's M0. So patient is suffering from T1, N0, M0. So you look up your guidelines and you'll give the patient's prescription. But if a patient comes to you and says, I have a tumor of 7 centimeter, or let's just say for the convenience 6 centimeter, I have ipsilateral hilar lymph node involvement, and yes, there's metastasis, but on the same side, and it's affecting the contralateral lobe. What's the stage? It's T2B. We talked about between 5 to 7, it's T2B. T2A was 3 to 5. So it's T2B. What does N stands for? Nodal involvement. Is there any nodal involvement? Yes, there is. Ipsilateral nodes are involved, so N1. Next one, metastasis. Is there any metastasis? Yes, there is. So M1A, because it's on the contralateral side, it hasn't gone very far, it hasn't gone distant. So now we have a stage of cancer that you will call T2B, right? N1 and M1A. Yeah, it's difficult to concur, it's difficult to memorize these things, but you have to know, because this is the only factor which is going to affect the kind of protocol that we're going to use on that patient. Now we're going to talk about, okay, we have cancer, we have carcinoma. It's metastasizing, it's affecting the lung, it's doing everything. But what's so special about lung carcinoma? Do you know men and women combined, lung cancer has the highest mortality in the world among cancers. Not even breast cancer can uh, deal with it. Lung cancers are so common. People are dying out of it. So, okay, all of these effects are fine. We now know all of it. There's some added dessert to it. It also has local effects. It also affects the patient locally. How can it affect locally? For example, I have a carcinoma at like this level. What is going to do? It's going to affect the local structures, these local nerves, these local even skin. So we're going to talk about these local effects. Patient will have cough and dyspnea. Obviously, patient will have cough and dyspnea. Why won't he? Patient is suffering from lung cancer. Patient is going to cough. That area of the lung that has been compromised is not taking place in any kind of oxygenation. So patient is going to have dyspnea. Patient won't have enough oxygen to sustain his life form. Next on, we'll have chest pain and hemoptysis. Chest pain will happen because structural damage is happening inside of it, and hemoptysis, you know, a lot of destruction is going on. Cells are being destroyed, cells are being metaplized. So hemoptysis will be there. Next on, we'll have obstructive pneumonia. We talked about obstructive pneumonia in the pneumonia section. If you want to revise that, you can go back and watch that lecture. But when a cancer, for example, it happened in a bronchi. For example, the carcinoma is present inside the bronchi. So that bronchi is blocked. When the size gets up to that level, it blocks that bronchus. So the lateral area to that bronchus is not getting any air anymore. So first side effect of it, that area is not communicating. That's a loss. That area of the lung is not communicating with the blood anymore. It's not getting any oxygen. But what's the second harm? Second harm is now all the bacteria and all the colonies will start growing there. There's no communication of air. They'll start growing there and they'll get pneumonia. They'll get more and more infections. So that's a local effect of carcinoma. Carcinoma is not doing that. It's doing its own thing. But due to carcinoma, these things are happening. Next on, we have pleural effusion. Pleural effusion, we talked about pleural effusion in the pleural effusion section. You can watch that video. But why is pleural effusion happening? When the carcinoma of the lung gets up to that size that it affects the pleural membrane, what happens? Transudates, exudates, water, pus, anything, literally any fluid can get accumulated between them and cause pleural effusion. It won't let the lung expand that much. So this cough, dyspnea, chest pain, hemoptysis, all of this will just worsen. Body will go into worst and worst form. CV system will go down and down. So all of these are local effects. But further on, we have very serious kind of effects. What about, let's talk about Pancoast tumors. Pancoast syndrome happens in Pancoast tumors or these lung tumors. So what happens in Pancoast tumors is it paralyzes the cervical sympathetic nerves. Just imagine that effect. It affects your nerves. It paralyzes the sympathetic activity to the cervical area. Next on, we have Horner syndrome. It causes Horner syndrome by affecting the nerve, and it causes anophthalmos, meiosis, and anhidrosis. So these two are the very serious kind of local effects carcinoma of the lung contains. Next on, we have paraneoplastic syndrome. Actually, there are paraneoplastic tumors as well. So what happens is that these paraneoplastic syndrome due to carcinoma of the lungs, these things are going to happen. It's going to affect all of these systems. You can see it's going to affect your skin, causes acanthosis nigricans. It's going to affect your skin, causes dermatomyositis and polymyositis in muscles. It affects muscles. It affects your joints. It affects your fingers. It causes clubbing of the fingers and myasthenic syndromes. Next on, it's going to cause endocrine syndromes and Cushing syndrome and SIADH. So all of these are happening due to paraneoplastic syndrome, but that is a consequence of what? Carcinoma of the lung. What are the other features of carcinoma of the lung? We have talked about enough of the features of carcinoma of the lung, but let's get into it more and more. So what the point is, the mediastinal spread, let's talk about two kind of spreads. Whether it can be mediastinal spread, whether it can be metastasis. So in mediastinal spreads, nerve entrapment syndromes happen. We just discussed them, which nerves are getting trapped and all of those side effects. Superior vena cava syndrome will happen. What is superior vena cava syndrome now? For God's sake, we have read enough of syndromes. What is superior vena cava syndrome? So the point is, when the size of the tumor or the carcinoma is too much that it blocks the superior vena cava, it causes superior vena cava syndrome. What will happen? It blocks the blood supply going back to the right atrium. So the peripheral, the peripheries will develop. The peripheries were not being used before, but now the blockage is too much that the blood cannot pass through. The blood pressure will rise. Inside the veins, the blood pressure will rise and will use the peripheries to get to the right atrium. It's called superior vena cava syndrome. But the severity of the syndrome actually depends. It depends whether the size of the tumor developed over the time, that the peripheries got time to develop, or it just happened overnight. So the side effects, so the effects of the superior vena cava syndrome depends on it. But if it's going to metastasize, extranodal metastasis involve adrenal glands. We just talked about what adrenal glands does to that, right? So extranodal metastasis involve adrenal glands, and it destroys you. Literally, it destroys you. How? Endocrine function wise. Next, we have spread to the brain, bone, and liver. We talked about it. It's going to get to the brain. It's going to get to the bone. It's going to get to the liver. When was it getting to the bone? When it was going in the other direction. It was going contralateral. What happens? When was the brain being involved? When the blood got disseminated. When the liver was being involved? When the blood was disseminated. Metastasis to regional lymph nodes. Now that's very common. We talked about it, that it does spread to regional lymph nodes after crossing the basement membrane. Next on, we're going to talk about molecular pathogenesis. So we talked about all of these risk factors. We talked about all of these things happening inside of them. But this is molecular pathogenesis, that even these contribute to it. Even any mutation in them can lead up to it. So there's this KRAS and MIC and FGR1 and EFGR. These are actually chemicals present inside of your body whose mutation, whose any kind of change can lead up to cancer. Chromosome 3, RBP53, that's also one of them. EML4 ALK and EML4 ALK translocations. If this translocation happens, you're going to get it. Then there's RAF, PIK3CA, ERBB2, ROS1. I know the names are difficult, but you have to remember them. You have to remember at least some of them so that you might give an example what are the molecular pathogenesis of them. Now let's talk about histological subtypes. We talked about all of them types. We talked about what are the types of cancers. What types of cancers are present in lung cancers. We're going to talk into those subtypes, and we're going to see what histologically, how can we identify them? They contain histologically what? And I'm going to tell you some morphological points as well, so that you might get to correlate them, right? So first of all, I'm going to talk about squamous cell carcinoma. This is what it looks like on morphology. And this is what it looks like on histopathological slide. So what you have to know that this contains orange stained keratinized squamous cell carcinoma in this slide, right? It contains hyperchromatic nucleus. You can see these hyperchromatic nuclei are present. So that's the identifying point for squamous cell carcinoma. So as we're talking about squamous cell carcinoma, we know it's made up of squamous cells. This is a carcinoma of squamous cells. And we talked about squamous cell carcinoma that the reason the reason behind squamous cell carcinoma is non-small cell carcinoma. We talked about squamous cell carcinoma as one of those carcinomas which propagate at a very steady or slow pace. Next on, we're going to talk about adenocarcinoma. We talked about adenocarcinoma before that. What was it? What was the point that I told you again and again about adenocarcinoma? The adenocarcinoma occurs in those people who do not smoke, their whole life. They haven't been even, given the passive smoking kind of thing. They have never been subjected to that even. So in adenocarcinoma, what we'll find histologically is that it contains glands, papillary structures, and has a bronchoalveolar pattern. You can see bronchus and then, dividing into alveoli. And it has cellular mucin inside of it, and solid pattern will be seen if it's poorly differentiated. So these are the points that you will look for. In atypical adenomatous, hyperplasia will be seen. Next on, we have adenocarcinoma in situ. We talked about all of the adenocarcinoma points in the last slide. But in this slide, what I'm going to tell you is that epithelial cell crowding occurs in this slide. In adenocarcinoma in situ, crowding occurs with or without stratification. It's not going to be important that stratification is happening, stratification is not happening. It's very important that you get the point that it's not important in this slide. And nuclei are elongated. You cannot see any kind of, oval or circular nucleus. They're elongated, and nuclear hyperchromasia is happening inside of it. So these are the points you have to remember for adenocarcinoma in situ. Next on, minimally invasive adenocarcinoma. These are the further subtypes of adenocarcinoma. You don't have to know all the details of them. You just have to know how to differentiate them and what to look for inside a histopathological slide. So you can see it's minimal invasive adenocarcinoma. We just talked about it, that some of them will have stratification, some of them will not have stratification, some of them will have elongated nuclei. It's all of that repetitive so that you might get the idea, you might get the gist of it, so that you can identify them on a slide when presented in exam. Next on, we again have this minimally invasive adenocarcinoma. We just talked about it. It's just to give you a kind of an exposure so that you might get to know what kind of stains or what kind of form it can get to you. Next on, we have another slide of invasive adenocarcinoma. And you can see in this slide, there's tan white surface cut, but you have central area of scar are present or necrosis is present, and it's usually well divided but non-capsulated. It's never going to be capsulated. Scars can be seen inside of it, white tan surface cut. So even this can be presented to you. So you have to know that these different slides, you cannot, so that you don't get confused with them. So this is again invasive adenocarcinoma. So invasive adenocarcinoma has further subtypes. We saw many of them slides. There's acinar adenocarcinoma. It contains acinar cells. We have papillary adenocarcinoma. It contains papillary cells. We have micropapillary adenocarcinoma. It has micropapillary adenocells. And next on, we have solid adenocarcinoma with mucin formation. Now, in this form, mucin formation is very evident. That's why it's called solid adenocarcinoma with mucin formation. Next on, we have invasive mucinous adenocarcinoma. And these are actually columnar cells with cytoplasmic clearing. You can see not more of a cytoplasm there, and you can easily identify these points, which I'm telling you, that they show apical and brush borders. They show apical brush borders inside of them. Next on, we have carcinoma of the lungs. There's some general features that you have to know while reading these carcinomas, that some non-small cell carcinomas can be treated with chemotherapy, right? Advanced stage adenocarcinoma respond to folate. And if there's mutation, we talked about those biological mutations, those mutations we talked about, EGFR mutation have better progression-free survival rather than others. Just these are 3 key points I wanted to share with you. Now let's get on to the next slides that we're going to talk about. Let's talk about large cell carcinoma. We talked about it. The large cell carcinoma is the carcinoma subtype of actually non-small cell carcinoma, and it's called large cell carcinoma because it contains large cells and it happens in the periphery. It starts in the bronchus and it occurs in mostly smokers. So you'll see these pleomorphic anaplastic tumor cells will be seen, and absence of squamous and glandular differentiation will be seen. You won't be able to differentiate between squamous and glandular inside of it. So that's the key point to know about large cell carcinoma if you get it on the slide. Next on, we have large cell neuroendocrine carcinoma. Whenever they say neuroendocrine carcinoma, one thing you should know about is that it's going to be secretory in nature somehow. So you can see hypercellular with numerous single, medium to large cells are seen in this slide. Hypercellularity, you can see hypercellularity. Small, medium to large cells are here. You can see multiple cells, some are small, some are medium, some are large. And it's 3-dimensional, widely sized groups are seen inside of this slide. And chromatin, prominent nuclei, abundant cytoplasm, sharp cellular borders, all of it are identifying points for large cell endocrine carcinoma. It's a slide of its own type. You don't see this kind of slide anywhere, so you won't confuse this one at least. And naked nuclei abundant but with viable subset of cells. When you look so closely, naked nuclei are visible. Next on, we have small cell carcinoma. We talked about small cell carcinoma. It's the most dangerous carcinoma there is. It propagates so rapidly that patient doesn't even get time to consult a doctor or go to some therapist or get time to decide whether the patient is going for treatment or not. In small cell carcinoma, what will be seen is round oval blue cells with minimal cytoplasm usually seen. Minimal cytoplasm, orange and blue cells are seen inside of this. Nuclear features finely dispersed chromatin are seen. No distant nucleoli, molding, smudging, high mitotic rate, stroma. All of these are evident inside of this slide. But you have to remember 2 to 3 of them, that they're blue and orange and these sizes are here. And there's minimal cytoplasm. And all of these structures are inside of it, which are widely spaced. No nucleoli is seen. All of these will be able to help you to differentiate a small cell carcinoma from other type of cancers. Next on, we have lung carcinoma with combined histology. These are called sarcomatoid tumors. This is what it looks like. These are high-grade tumors with sarcomatoid and carcinomatoid components. These both components, you can easily differentiate these both components. Now, this is a slide which is very distinctive in its own nature, that it contains 2 types of cells. Sacromatous component has spindled, round, and pleomorphic giant cells. Spindled, round, and pleomorphic giant cells will be seen in sacromatous area. And chondrosarcoma, rhabdomyosarcoma, rarely liposarcoma are the reasons behind it. This is the pathology seen in them topics. You can see this kind of pathology. Next on, we have giant cell carcinoma. So what we look for is discohesive, polygonal, mono and multinucleated giant cells with abundant cytoplasm and prominent nuclei. You can see them. But the most important point to note is neoplasmic, highly pleomorphic giant cells are seen. You can see these neoplasmic giant cells inside of it. So that's the identification point for giant cell carcinoma. Next on, we have favor adenocarcinoma. 3 points you have to remember for favor adenocarcinoma are these are large cells with large size and abundant cytoplasm. They have a nucleus staining for TTF1, and they have pepenculo stain of fine needle aspiration when it's performed. Next on, we have favor squamous cell carcinomas histopathology and where it's seen. So those 3 points I just told you, these fine needle things, all of these are done here. All of these are depicted here. Next on, we have non-small cell carcinoma, not otherwise specified. So it's just telling you that you can see this kind of slide too for a non-small cell carcinoma. Next on, we have carcinoid tumors. Carcinoid tumors have a very different kind of pathology actually. It's seen like this. Carcinoid tumors are like this. I'm going to tell you about them in a while. And these are the types of carcinoid tumors. Either they're typical carcinoid tumors or they're atypical carcinoid tumors. So the carcinoid tumors can either be typical or atypical. That's the point being made here. Or what are carcinoid tumors? Carcinoid tumors are actually those tumors, those small tumors which start somewhere else. They start at the digestive tract. Most probably they're going to start at the digestive tract. So they migrate here and get into that state, and there they form this kind of tumors. Now, they're not formed in the lungs originally. They're not lung tumors, but they came here. They metastasized to lung. And this is what it will look like on a slide. So what are the clinical features of a patient suffering from carcinoid tumors? The features are, patient will have hemoptysis, just like the tumors of lungs. Patient will have regional lymph node metastasis, just like the lungs. Patient will have post-obstructive pneumonitis. We talked about it. Why does that happen? And then dyspnea and female predominance will happen. So all of these things we have already talked about them. These are actually clinical features of any kind of tumor which is happening and is metastasizing, specifically the lungs. Next on, we have rare pulmonary tumors. These tumors are very rare. They have been reported like once or twice inside their whole history. So we're going to talk about them so that you must have a glitch about them at least. If you heard of inflammatory pseudotumor, you don't go like, I've never heard of that. So these are actually fibroinflammatory with variable numbers of plasma cells, lymphocytes, histiocytes, and neutrophils. And they are multinucleated, as you can see, 1, 2, 3, 1, 1, 2, 3. And they have hemosiderin inside of them. You can see the hemosiderin. And calcification may resemble nodular fasciitis. And fibrohistocytoma or fibromatosis can be seen inside of the slide. You don't have to remember everything of it, but you just have to remember the gist of it. Next on, we have inflammatory pseudotumors morphology. This is what it looks like. Next on, we have pulmonary epithelioid hemangioendotheliomas. Even the name gives you cramps, right? So it is actually well-developed basal. It contains well-developed basal lamina, pinocytotic vesicles, occasional vibral pellet bodies are seen inside of it. So this is pulmonary, meaning lung, epithelioid, meaning it contains the mark of epithelium, hemangioendothelioma, it's going to be secretory in nature too. Next one, we have pulmonary blastoma. These are well-formed tubular glands surrounded by a cellular stroma of embryonal appearance. Right, and it resembles Wilms tumor of fetal lung disease at the age of 10 to 16 weeks, actually. Glandular cells are tall, columnar, often with clear cytoplasm. You can see this one, often with clear cytoplasm, and subnuclear and supranuclear cytoplasmic vacuoles are seen inside of it in pulmonary blastoma. Next on, we have mucoepidermoid carcinoma. These are circumscribed tumors, may not be attached to surface. Let me show you its morphology. Yeah, this is what it looks like. These are circumscribed tumors, may not be attached to surface. multilobulated nodulocystic tumors extending throughout the dermis in this pathology. So the dermal lobules or cystic growth of low-grade epidermoid, intermediate, mucinous cells and clear cells are seen in the histological side of it, and cribriform nest of epithelioid cells contain glandular cells. Basically, they can also contain other cells, but they basically contain the glandular cells. Next one, we have adenoid cystic carcinoma. Now it's actually a cyst, but it's also a tumor. So it's a matrix. You can see it's a matrix containing basaloid, and it's stained differentiate quick smearacine and metachromatic matrix sphere with sharply defined borders, and cytologic features contain uniform basaloid cells with scant cytoplasm and dark angulated nuclei. Dark angulated nuclei are seen. Cytoplasm is basically scant, and it is uniformly basaloid cells are seen inside of it. Next on, we have pulmonary artery sarcoma. Microscopic finding in pulmonary artery sarcoma. This is a sarcoma which occurs in the pulmonary artery, that was called pulmonary artery sarcoma. It's not like a tumor of the lung, but it's distant, but it's gonna get there. That's why they are called far pulmonary cancers, that we discussed that before. So microscopic finding in this will be abundance of spindle cells with pathological mitosis. This white area, you can see this a lot of mitosis going on, and hematoxylin and eosin staining is seen. Hematoxylin and eosin staining will be seen very differently. You can actually identify them. Next on, we have pulmonary lymphomas. So pulmonary lymphomas, we're going to talk about what pulmonary lymphomas will look like. These are going to be dense, monotonous population of centrocyte-like cells, often with residual germinal centers and lymphoepithelial lesions. It may have plasmacytoid differentiation too. You can see the same here. It's actually been zoomed here. Next on, we have extrapulmonary tumors. Those tumors which does not occur inside the lungs, but they get to it one way or another. So these are cannonball metastases. These cannonball metastases refer to well-defined spherical nodules scattered over both lungs, being a classical presentation of hematogenous tumor spreading. Striking progression of lung metastasis without established primary malignancy can raise a diagnostic challenge in this case. You can see this histopathological pattern of it. So that's all of it. So what we learned in this lecture are a lot of histopathological slides, but you don't have to remember every one of them. You just have to remember what points you have to use to identify them slides. We talked about what staging of the cancer is. We talked about what a benign tumor does to the lungs. We talked about the types of lung cancer. We talked about what a small cell carcinoma, what is non-small cell carcinoma, how do we define them, how do we stage them, and after staging we have to know the risk factors. We can actually we are actually going to treat the patient according to the stage. Then we talked about all these histopathological slides so that we might get to identify them whenever we are presented with them. So one thing you have to remember is that staging is the key to all of it. So once we stage the disease, we get the treatment of it. Thank you for watching. Keep watching sqadia.com.